Welcome to the self-evaluation episode of the ASCO University Weekly Podcast. My name is Apar Kishor Ganti, and I am the Associate Director for Clinical Research and co-leader of the Thoracic Oncology Service at the University of Nebraska Medical Center, Fred and Pamela Buffett Cancer Center. Today, we feature a self-evaluation question of EGFR mutated lung cancer, and I will begin by reading the question stem. A 52-year-old man with a 3-year smoking history during his early 20s is seeing you for initial consultation after presenting with worsening dyspnea and cough over 1 month. Chest X-ray showed a right lung mass. A CT scan of the chest showed a 5 cm mass in the right lower lobe and enlarged hilar and mediastinal lymphadenopathy. A PET scan revealed a hypermetabolic lung mass and right hilar and mediastinal lymph nodes, in addition to hypermetabolic lesions in the liver. Ultrasound-guided biopsy of one of the liver lesions was performed. Pathology showed a moderately differentiated adenocarcinoma, positive for CK7 and TTF1 and negative for CK20. Molecular profiling revealed an EGFR mutation with exon 19 deletion. MRI of the brain showed no metastatic lesions. Which of the following statements is the most accurate regarding this patient's prognosis and management options? The choices are A. The presence of EGFR mutation in this patient's cancer makes his prognosis and expected survival worse than patients without EGFR mutation. B. EGFR exon 19 deletion is considered a predictive biomarker in metastatic adenocarcinoma of the lung. C. Platinum doublet therapy regimens are less effective in the presence of EGFR mutations as compared to cases without EGFR mutation. And D. PD-L1 checkpoint inhibitors are contraindicated in patients with metastatic EGFR mutant adenocarcinoma of the lung. The correct answer to this question is B. EGFR exon 19 deletion is considered a predictive biomarker in metastatic adenocarcinoma of the lung. Somatic mutations in the gene encoding EGFR are detected in about 15% of non-small cell lung cancers in the United States. 90% of these mutations are either exon 19 deletions or exon 21 L858R point mutations. These mutations increase the kinase activity of EGFR, leading to hyperactivation of the downstream pro-survival signaling pathways. The presence of these mutations makes the cancer highly sensitive to the treatment with EGFR tyrosine kinase inhibitors. What about the other options? While the presence of EGFR mutations predicts for response to EGFR-targeted therapy, it is uncertain if these mutations carry any prognostic value independent of therapy. Platinum doublet chemotherapy regimens are appropriate treatment options in advanced mutated EGFR lung cancer. In the IPAS study that compared carboplatin paclitaxel to gefednib, the response rate with chemotherapy was 47.3% in the mutation-positive patients as compared to 23.5% in the mutation-negative patients. Hence, platinum doublets are often used in the second or third line settings. PD-L1 checkpoint inhibitors are currently FDA approved for treatment of all advanced non-small cell lung cancers, including EGFR mutation patients, after progression on first-line TKIs. However, retrospective studies have shown that these agents may not benefit patients with driver mutations like EGFR and ALK. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more information on lung cancers, visit the Comprehensive E-Learning Center at university.asco.org. Thank you.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.